Okay, so based on the PK profile, that is whether your drug is concentration dependent killing or it has time dependent killing with post antibiotic effect. So whether you need a single dose or you need multiple doses, depending on that you have to choose your drug based on the infection. Next factor is the penetration of the drug. Again, most of the drugs, as I told, do not penetrate deep tissues. Exception is your fluoroquinolones. So when you know that there is deep-seated infection like intra-abdominal infections or the patient having infective endocarditis, go for fluoroquinolones. Next is the drugs like penicillins and aminoglycosides, they do not penetrate normal meninges. They'll penetrate only when the meninges are inflamed. So if there is meningitis, you can use penicillins and aminoglycosides. Otherwise, in normal patients, they do not penetrate meninges. The next factor is the route of drug administration. Given a choice, anyone would like to go for oral. But few drugs are there which do not have action when given orally. They act only when given parenterally. Examples are aminoglycoside, penicillin G, and vancomycin. Fine. So these are the different factors: patient, drug factor, and the organ related factors which affect your choice of antibiotic. Now, after listening to so many factors, when we call that this drug is an ideal antimicrobial drug, so the drug should have highly selective toxicity to the microorganism. It should be either less toxic or it should not cause any toxicity to the host. There should be low propensity for development of resistance. It should not cause allergy or hypersensitivity reactions to the host. It should have rapid and extensive tissue distribution. As I told you, if your drug is not penetrating well, it will not be of any use. It should not cause drug-drug interactions with other drugs. And as usual, your drug should be cheaper or relatively inexpensive. Fine. So as we know, most of the infections may not give any response to a single drug. So in that case, we have to think about combinations, or sometimes there is mixed infection. So you have to go for combination of drugs. As far as possible, go for single agent therapy. But in few cases, combination of 2 or many drugs is recommended. This is with specific purpose, and you cannot just give blindly 2 or 3 drugs thinking that when 1 is better, 2 will be the best and 3 will almost cure your disease. This is not the case. So whenever you are combining 2 or 3 drugs, you have to follow the rationality. You cannot just give multiple drugs to a patient. So what are our objectives when we want to combine the antibiotics? So our aim is to achieve synergism. All of you know what is synergism. Second is to reduce the severity of adverse effects. Thirdly, the main aim is to prevent emergence of resistance. As we know, we are already dealing with superbug, which is difficult to treat. And fourth one is to broaden the spectrum of antimicrobial action. So we'll see these different objectives bit in detail. So coming to the, as we have told, that to achieve synergism. So when we add two drugs, either they have got additive, supraadditive or antagonistic effect. So when we combine two drugs, if one decreases the MIC of another by 25% or less, we call it as synergistic. If it is decreased between anything between 25 to 50%, we call they have additive effect. If MIC is reduced by one drug more than 50%, then they have antagonistic effect. Okay, so synergism is nothing but one drug sensitizes organisms to the action of other drug. So how it is manifested? It is manifested as more rapid lethal action. It results in faster cure. And also when we combine, there is prolongation of post-antibiotic effect. You can see a few examples. The beta-lactam when we combine with aminoglycosides. So it shows synergistic activity against gram-positive, gram-negative bacteria used in the treatment of serious infections when rapid killing is essential. Example, treatment of subacute bacterial endocarditis caused by Enterococcus species. So now, in this combination, how they are synergistic to each other. So as we know, in the previous class, in classification we have seen the penicillins or beta-lactams act by inhibiting cell wall synthesis. So by doing this, they increase the penetration of aminoglycosides. So this is how this combination is synergistic. The other example is rifampicin is combined with many antibiotics to achieve rapid killing and faster cure. So every combination is unique. Same drugs may be synergistic for one organism but antagonistic to other. So whenever we are combining, follow the general guidelines. Two static drugs are always additive rather than synergistic. Example, tetracycline and chloramphenicol. Both of them are static. But here the exception is sulfonamides with trimethoprim. This is chlorpromazole. This has supra-additive effect. And then we always combine sulbactam or clavulanic acid with amoxicillin or ampicillin for the treatment of H. influenza and gonorrhea infection. Secondly, two-sidal are frequently additive and sometimes they are synergistic. So here we get faster cure, decreased chance of relapse by complete eradication of pathogen. Examples, we can combine penicillin with streptomycin or gentamicin. So as told previously, penicillin increases penetration of gentamicin by inhibiting cell wall synthesis. We can combine vancomycin with gentamicin to treat enterococcal subacute bacterial endocarditis. The next example is carbanicillin, anticacillin plus gentamicin in treatment of Pseudomonas infection, especially in neutropenic patients. To treat Pseudomonas infected prosthesis, we can combine ceftazidime with ciprofloxacin. And as we know, in tuberculosis, we have to use multiple drugs, as use of single drug leads to resistance. So in tuberculosis, we use 2, 3 or 4 drugs. And the most common combination is Rifampicin with INH. Now examples of cidal drug with static drug. So either you get synergism or antagonism based on organism. If organism is highly sensitive to cidal, then response to combination is equal to static drug given alone. So this causes apparent antagonism. Why is this so? As we know, static drug inhibit the growth or multiplication, whereas the cidal drugs act primarily on rapidly multiplying. So here, when you combine static with cidal, you are getting antagonism. Your cidal drug will not be effective as the static drug is inhibiting the growth. Example, when we combine penicillin, which is a cidal drug, with a static drug like tetracycline for treatment of pneumococcal infection. So actually this has happened when they have used this combination for the treatment of pneumococcal meningitis. There were many deaths, and the reason being your penicillin was absolutely not effective. Next is penicillin with erythromycin for group A streptococci, and then nitrofurantoin with nalidixic acid for E. coli. If organism has low sensitivity to cidal, then you get synergistic activity. Example, when you combine penicillin with sulfonamides for the treatment of actinomycosis, and streptomycin with chloramphenicol for Klebsiella pneumonia infection. And in leprosy, we combine rifampicin with dapsone. Wherever possible, use synergistic combinations for treating in full doses. Next is why we prefer the combination: to reduce severity or incidence of adverse effects. So what is the advantage? How the adverse effects can be reduced? When you are combining and you are getting synergistic effect, the doses needed will be less. As the doses decrease, the adverse effects automatically will be less. So the other condition where you need low doses and the combination is the drugs which have low safety margin, or what we call it as drugs having low therapeutic index. So if you are using them alone, you have to use it in higher dose, and that can cause unacceptable toxicity. Example, streptomycin is a drug having low therapeutic index or low safety margin. So you combine this with penicillin. Penicillin has got high therapeutic index. It is a safer drug. So you combine these two drugs, thereby reducing the dose of streptomycin. So this combination is used again for the treatment of SAB caused by Streptococcus faecalis. Next we use combination of Amphotericin B with Rifampicin or minocycline. Here we are combining these drugs to increase the action of amphotericin. Rifampicin helps in enhancing the action of amphotericin B. The another combination is Amphotericin B with flucytosine. So when you combine these, the duration of treatment will be less. Thereby, you come across less adverse effects. And the next very important factor why we go for combination is to prevent emergence of resistance. So this is because mainly selective pressure from antimicrobial therapy. So whenever you are combining, we should see that the mechanism of action of two drugs is different. They should not act by the same mechanism of action. Then only it becomes synergistic effect. So thereby preventing the resistant mutant population from emerging as the dominant strain and causing therapeutic failure. So when we are combining two drugs, it should provide a better chance that at least one drug will be effective. And that is why combination drug therapy is used as the standard for treatment of chronic infections, wherein the duration of treatment is longer, and then there are high chances of resistance. So which are such conditions where combination is a must? So as all of you know, tuberculosis, leprosy, H. pylori infection, malaria and HIV, we always go for 2 or 3 or sometimes 4 drug combination. So this helps in reducing the dose of individual drug, also prevention of resistance. And then the other objective is you broaden the spectrum of action of antimicrobial agent. So especially this is very, very important when the patient is having mixed infection, wherein the different organisms are causing the problem. So we have to use different groups of antibiotics based on their spectrum of activity. Or the other situation where you need the combination is when there is severe infection, you start with combination, later on based on the clinical improvement, your culture sensitivity report, you can change it or you can reduce the drugs. And some drugs, as we know, are not absorbed orally. Same is true with even some antibiotics. They do not have any systemic absorption. So such drugs are used only topically. Example is your Polymyxin B or Nystatin. Next is to extend the antimicrobial spectrum beyond that achieved by use of single agent for treatment of polymicrobial infection or mixed infection. So when infections are thought to be caused by more than one organism, we have to go for combination treatment as it extends the antimicrobial spectrum beyond that achieved by single drug. The next situation is most intra-abdominal infections are usually caused by multiple organisms with variety of gram-positive, gram-negative and anaerobes. Antibacterial combinations like third generation cephalosporins or fluoroquinolones plus metronidazole can be used as a potential treatment option in such cases, and they are more cost effective compared to single agent like carbapenem, which is a costly drug. So as I told, if there is a serious life-threatening infection, when critically ill patients require empiric therapy because you cannot wait for the lab reports, go for combination. For healthcare associated infections or hospital acquired infections, usually they are caused by bacteria resistant to multiple antibiotics. So when a patient who has been hospitalized for several weeks develops septic shock and blood cultures show growing gram-negative bacilli, so start initial therapy with 2 agents that have effect against gram-negative, especially as we know Pseudomonas is the main organism seen in hospital acquired infections, which is both a nosocomial pathogen and frequently resistant to multiple agents. So go for anti-pseudomonal beta-lactam with fluoroquinolone or aminoglycoside. So these are the different situations where it is a must to go for combination of antimicrobial agents. Fine. So far we saw how the combination is useful. There are some disadvantages also of such combinations. So preferably, as we say, go for a single agent. So it is not a rational outlook in diagnosis of infection and choice. So as we know, multiple drugs, more chances of adverse effects. Sometimes toxicity of one drug is increased by another. Example, vancomycin with tobramycin or gentamicin cephalothene. When we use this combination, there is increased risk of kidney failure or increased damage to the kidneys. There are increased chances of superinfection whenever you go for combinations. When you are using inadequate dosage of synergistic drugs, there is chance of resistance, and again the multiple drugs, the cost will be higher. So this is all about the combination of antimicrobial agents, how it is advantages, how it is disadvantages. Now coming to the almost to the end of the class, we have to, so far we saw that yes, this is the infection and this antibiotic you have to give. So every time is it necessary that whenever the infection occurs then only we have to treat? Or there are some situations where can we use prophylactically to avoid this infection? Yes. So that is true. We can use antimicrobial agents prophylactically. So we will see in next few slides about prophylactic use of AMAs. So what do you mean by this? Antibiotic prophylaxis is the use of antibiotics before surgery or a dental procedure to prevent a bacterial infection. Apart from this, there are few medical conditions also where we use antibiotics. We will go through it in further slides. So whenever you are using it before surgery, so it should be initiated within 1 hour before incision or within 2 hours if the patient is receiving vancomycin or fluoroquinolones. So the drug of choice should be appropriate for their procedure, and ideally it should be discontinued within 24 hours of surgery if there are no any other risk factors. So by doing this, we are preventing the infection complications using antimicrobial therapy. Because whenever you are incising, the surgical procedures can introduce bacteria in the blood, leading to bacteremia, which can colonize and infect different parts of the body. So by giving surgical prophylaxis, we can reduce the occurrence of such infections. Then how will you select the patient? Patient should be selected if the medical condition or the surgical procedure is associated with higher risk of infection. So what are the 3 basic principles you should know whenever you are giving prophylaxis? Number 1, the high risk of infection. You should be aware of the likely infecting organism and their susceptibility, and prophylaxis to be administered at the time of risk. Now, few examples I'll give where we use prophylaxis against specific organisms. So this is highly satisfactory as the choice of drug is clear cut and targeted. A case of rheumatic fever. We give long-acting Penicillin G every 3 weeks against group A streptococcal infections, as these patients, if they develop any abnormalities like mitral stenosis, mitral incompetence, they are more prone to go for subacute bacterial endocarditis. So to prevent that, lifelong they have to take long-acting Penicillin G every 3 weeks. In case of tuberculosis, if there is any open case at home, all the home contacts and the children, and also if a HIV positive patient is there, we have to give them prophylactic anti-tubercular drugs. Either you give INH alone or INH along with Rifampicin. Any patient of HIV with low CD4 count, so they are more prone for infections, give them either azithromycin or clarithromycin. Now, the healthcare workers, if they come across needle stick injury while handling any case of HIV, they should be treated with zidovudine and lamivudine plus or minus indinavir. If a pregnant woman is HIV positive, we have to treat her with zidovudine. Along with that, we have to treat a newborn baby either with zidovudine or nevirapine syrup for 6 weeks. A patient of meningococcal meningitis, we have to put on rifampicin, sulfadizine and ceftriaxone. A case of gonorrhea or syphilis, before or immediately after contact, we have to give ampicillin or ceftriaxone. As we know, in all endemic zones, we have to give prophylactic treatment for malaria with either doxycycline or mefloquine. In case of cholera, we use tetracycline, whereas for influenza, it is amantadine. Now, sometimes when there is high risk, we have to give prophylactic antimicrobials. This may be satisfactory in certain situations, but is controversial in many. So if a patient is undergoing dental extraction, tonsillectomy or endoscopies, there is damage to the mucosa, harboring organisms, and this can lead to bacterium. If the patient has normal host defense, nothing will happen. But if the patient has valvular defects like stenosis or incompetence, it can cause endocarditis. So in such cases, go for amoxicillin or clindamycin few hours before the procedure. If any patient has to be catheterized or instrumentation for urinary tract, we have to treat with cotrimoxazole or norfloxacin. A patient having cardiovascular lesions, we have to give either ampicillin, gentamicin or vancomycin. Patients with chronic UTI who have abnormal urinary tract, the drug of choice is cotrimoxazole or nitrofurantoin. Patients with COPD, we have to give prophylactic ampicillin, doxycycline or ciprofloxacin. In immunocompromised patients, the drugs of choice are penicillin or cephalosporins, aminoglycosides or fluoroquinolones to prevent septicemia. Okay, now prophylaxis of surgical site infection. This is your 5-mark short note. It's an infection that occurs at or near a surgical incision within 30 days of the procedure or within 1 year if an implant is in left place. So the infection could be either superficial incisional infection, or it could be deep incisional infection, or it could be the infection of deep space or organ. So what is our aim here? Reduce the incidence of surgical site infection with minimal alteration of normal bacterial flora of host and minimal adverse effects. So by doing this, what are the advantages that we got? The high incidence of wound infection after head and neck operations that involves incisions through oral or pharyngeal mucosa, it has decreased. The post-operative morbidity became less. Hospitalization shortened. So the overall cost attributable to infection is reduced. So many antibiotics require single dose given within 30 minutes of skin incision to provide adequate tissue concentration throughout the operation. Additional doses during the procedure are advisable if our surgery gets prolonged for more than 4 hours, if there is major blood loss, or if you have used an antibiotic with shorter half-life, then you have to give additional dose. So when you are choosing a drug for prophylaxis, again different factors play a role, and it should be based on the type of operation, kinetics and toxicity of the drugs, microbiologic characteristic of the operative site, antibiotic sensitivity specific to the particular hospital environment. The regime should be compatible with findings from the hospital infection control wound surveillance report. This is very, very important to prevent emergence of resistant organisms. So prophylaxis plays a major role, especially in hospitals with high incidence of infection with MRSA or methicillin-resistant organisms, Staph aureus, Staphylococcus epidermidis, or with newly vancomycin-resistant organisms, which are deadly infections. Okay, fine, you are using, but how long we should use? So you should start prior to skin incision for maximal benefit. There is no advantage if you continue it beyond 24 to 48 hours post-operatively. Fine. So now, depending on the type of procedure to be performed, this surgical chemoprophylaxis based on wound. The wound itself is classified into 4 different types. Clean, those that do not open body cavities not associated with inflamed tissue. Clean contaminated, wherein there is opening of body cavities like GIT or genitourinary tract, or the wound can be contaminated. Procedures which involve acute inflammation or visible wound contamination, or the wound can be dirty, meaning operations performed in the presence of pus, previously perforated viscous or open injuries which are more than 4 hours old. So if depending on the wound, your prophylaxis differs. So apart from that, whenever we are using prostheses or foreign materials, they have a high risk of infection, as we have seen, especially in orthopedic procedures. Skin commensals mostly implicated in periprosthetic infections. Any procedure that causes transient bacteremia, usually cleared by Arrhea system, may result in endocarditis in at-risk patients. Preferably, we do not give any prophylaxis for dental procedures or procedures of upper and lower GI if the patient host defense is good. Patients with repeated UTI, mainly due to anatomical abnormalities, have to be given prophylactic treatment. So these are the few drugs commonly used for surgical prophylaxis. Oral single dose given 1 hour before procedure. Amoxicillin, cephalexin, cefadroxil, clindamycin. Whereas parenterally we go for ampicillin, cefazolin, vancomycin, clindamycin, cefuroxime with metronidazole, and gentamicin with metronidazole. So you have to read about surgical prophylaxis. This is again your 5 marker short note. Fine. So we have learned so many things, general considerations of chemotherapy. In spite of available of so many drugs, so much of knowledge, sometimes there is failure of antimicrobial therapy. So what are the causes of this failure? It can start with the wrong choice itself. Secondly, if we do not start it on right time, if there is inadequate source control, if the antimicrobial blood levels are inadequate, your drug is not able to reach the site of action. There may be antimicrobial neutralization, or what we call it as antagonism. There can be unsuspected secondary bacterial infection, or there could be super infection. Next is non-bacterial infection. The most common causes in children, the URTI is commonly viral infection, but we go on giving them antibiotics, or it could be non-infectious source of illness, like it can be a inflammatory disorder, it can be a collagen disorder, and the patient is having fever. We go on thinking that it is a bacteria and we give antibiotics without any effect. So this is all about today's class. Take down the 5-marker questions, mainly surgical prophylaxis. Thank you.